Oh my god. Let's see how this goes. Haven't been live in the past 2 days because I've been like really sick. But I'm feeling alright right now, so let's see. I think this is where we left off last time. Yeah, this is where we left off last time. And we've still got quite a bit of metabolism to get through, so I'll try to get through as much of it as I can before it's bedtime. Okay. Let's let everybody know that we're live. Can't wait to be perfectly not sick anymore. It's really bad to get sick after you eat. Like, come on, I've been fasting all month and now I'm just sick. Seriously. Alright, so a lot of people have been asking though, what's the difference between these biochemistry streams and the ones I've been doing in other playlists. So this entire playlist with the complete first aid 2019 or whatever, it's going to go from start to end and do all of first aid, right? So one major difference in biochemistry, at least, will be that I added some more questions into biochemistry, specifically from Amboss. So those are some of the things that might be missing in the other playlists. And then on top of that, this playlist will go on and do like immunology, microbiology, and so on as I keep streaming. So those are going to be the key differences you want to watch out for. Alright, I'm going to get started now. So last time we finished up, we talked about the HMP shunt, or the pentose phosphate pathway, and G6PD deficiency, because G6PD is one of the enzymes of the HMP shunt, right? One thing I forgot to mention in the last video was the sites of the pentose phosphate pathway, right? So it's very important to know every process you look at. It's very important to know where that process occurs, right? Because not every process takes place everywhere. So the HMP shunt occurs at the lactating mammary glands, not just mammary glands, but lactating mammary glands, the liver, the adrenal cortex, where you actually make fatty acids and steroids, and in red blood cells, right? Very important for this to occur in red blood cells, because G6PD deficiency, right, which is basically a deficiency of the entire pentose phosphate pathway, ultimately has the most damage in red blood cells, right, which is what we learned when we looked at G6PD deficiency. So that part is very important to remember. And don't forget that there is no ATP used or produced when you do the pentose phosphate pathway. So those are two very tricky type of questions you can get on the pentose phosphate pathway. So don't fall for that. There's nothing else to really bother you besides those things. The rest of the information is pretty straightforward. We already talked about the products that are formed in between, oxidative versus non-oxidative, and then we talked about all the issues that come from G6PD. And we did some of these questions. So now moving on, we have this page where they talk about the disorders of fructose metabolism and the disorders of galactose metabolism. Alright, so if you get a question on any of these guys, FABGUT, FABGUT, this is one of the best ways to remember the more horrendous ones of each type. So let's talk about them and then we'll get there. Fructose metabolism. So fructose is found on sucrose also, so you want to avoid that as well. Right, and what's essential fructoseuria? So essential fructoseuria is a deficiency of fructokinase. So you have this image down here showing you fructokinase, aldolase B, and then you also see triose phosphate isomerase and triose kinase. In fructokinase deficiency, there's really not much of an issue, right? It's benign, asymptomatic condition. Fructokinase deficiency is kinder as opposed to hereditary fructose intolerance. So we'll get there. Fructose won't be trapped in cells because remember, when you add when you add a phosphate to any of these sugars, they get stuck inside the cell, right? We talked about this in glycolysis as well. So fructokinase, being a kinase, uses ATP to add a phosphate to the fructose, and then this fructose 1-phosphate gets stuck in the cell, and you use up an ATP that you won't really get to regenerate anymore. So that's pretty bad. However, essential fructosuria, with this being the enzyme that's not working, you never do that. So all you end up having is too much free fructose, right? And even that gets taken care of, because what you have to remember, and what most of your questions are going to be about, is hexokinase, right? Hexokinase becomes the primary pathway for converting fructose to fructose 6-phosphate. So essentially, fructokinase gets replaced by hexokinase. So if you have fructokinase deficiency, it's not the worst thing on earth at all. In fact, you might not even notice any symptoms from that, because hexokinase will do the job. All right. So what symptoms will you see? Well, some fructose might appear in the blood and urine, and disorders of fructose metabolism cause milder symptoms than analogous disorders of galactose metabolism. Right. So even the first one, which is galactokinase deficiency, is worse. Excuse me. Is worse than the essential fructosuria. Alright, so we understand now that without fructokinase, you're just going to have a lot of fructose, and hexokinase is going to take over and do the job for you. Alright, so what's hereditary fructose intolerance? Here you have a deficiency of aldolase B. Now, without aldolase B, your issue is now stuck right here, right? So you already did the fructokinase job. You made a fructose 1-phosphate. And now this fructose 1-phosphate is stuck inside the cell, and you cannot break it down anymore. Right? So you're not going to go from fructose 1-phosphate to DHAP and G3P anymore. Right? This is the G3P right here. So no more DHAP, no more G3P. You're not going to keep going further with the various breakdowns of fructose, and that's bad. So you're losing ATP, your fructose is all inside the cell. Now you're going to start seeing symptoms. Fructose 1-phosphate accumulates, causing a decrease in available phosphate, losing ATP. This results in an inhibition of glycogenolysis and gluconeogenesis, right? So now that already in itself is a very bad thing right there, right? So you can no longer break down glycogen, nor can you make new sugar. So those two symptoms can actually lead to hypoglycemia, which is right here, right? You get hypoglycemia. Without being able to break down glycogen or making new glucose, you're going to have hypoglycemia. Symptoms present following consumption of fruit, juice, or honey, any of these things that have sucrose or fructose in it. Urine dipstick will be negative, right? Because a urine dipstick always only tests for glucose. And reducing sugars can be detected in the urine. Now, this thing is very non-specific. This actually even occurs in the galactokinase issues, right? So if you see reducing sugars are detected, it doesn't mean that it must be hereditary fructose intolerance. It could even be one of the galactose issues. So other than that, the other issues you notice are jaundice, cirrhosis, and vomiting, right? So that's really bad now. Compared to here, where you really had no symptoms whatsoever except a little bit of fructose being found, now you have a major issue. Hypoglycemia is already pretty bad. Depending on what age this child might be, it's going to be really, really bad. And then the jaundice and cirrhosis and vomiting, you don't want any of that in any patient. So the only treatment you have is to decrease the intake of both fructose and sucrose in all of these patients, right? You can't do anything. So this is where the FAB part is, right? Because FAB is fructose is to aldolase B, because that's the worser, I guess would be the word. That is the more bad condition of the fructose metabolism issues. And gut galactose is for uridyl transferase, because this one over here with the galactose 1-phosphate uridyl transferase deficiency is the more bad condition of these two guys. Before we get there though, I do want to make sure you guys understand that these two enzymes are also pretty important. Right? Triose phosphate isomerase does take DHAP and make G3P, and triose kinase takes glyceraldehyde and makes G3P, and G3P was one of the things that gets sent into glycolysis, right? We saw this earlier. This also happened with glucose becoming glucose 1-phosphate, then making DHAP and glyceraldehyde, and then giving 2 G3Ps, which give 2 pyruvates, and so on and so on and so on. So very important to remember that that's all not going to be working. Now, here we have a question. So this one says, a 6-month-old boy is brought to the emergency department by his mother because of recent onset vomiting, irritability, and jaundice. He was born at term and had been healthy until the onset of these symptoms. He has all vaccinations. He had been breastfed exclusively until 1 week ago when cereals and fruit juices were introduced to his diet. Further evaluation reveals hepatomegaly and abnormal liver function tests. What enzyme is most likely deficient in him? So the cereals usually just hints at milk, and this is not a lactose issue at all. But the fruit juices are hinting at fructose, right? And you can tell that this 6-month-old baby has a couple issues, and something's not right with the liver. So it's very symptomatic. So it cannot be essential fructosuria because fructokinase deficiency gets replaced by hexokinase, which means you don't have any symptoms whatsoever for the most part. And on top of that, no diet changes are even needed. Right? No diet changes are needed. That's another trick question you can get on a patient with essential fructosuria. So this must be a patient with the FAB thing, fructose aldolase B issue, right? So aldolase B is deficient. Since there is no mention of cataracts, it cannot be a galactose issue. Fructokinase deficiency would be completely benign for the most part. Aldolase B deficiency causes the symptoms seen, and undiagnosed, it can lead to eventual liver and renal failure. Right, so in this explanation, I mentioned the cataracts, right? So now we're going to see that with the two galactose issues, right? So how do you get galactose? Galactose is galactose itself, or you can get it from lactose as well, right? And in that question we just looked at, they mentioned cereals, which you can usually assume comes with milk. So it could have been a question about galactose deficiency as well, but it wasn't. Excuse me. Yes, I am back, and I'm a little better. I was really bad like 2 days ago. I couldn't really talk, and my eyes were really bloodshot red. And I actually woke up. I woke up Saturday morning looking really, really messed up. I took a picture of myself because I was like, this is the worst I've looked in a long time. Like, my eyes were super swollen. It looked like I had a really bad allergic reaction. And not only were they super swollen, but they were both bloodshot red. And I've never been like that before. And my throat was hurting every time I would try to swallow. So it got really bad Saturday. And then Sunday, Saturday I had to go see guests at their house. We were invited for an Eid dinner. And the Sunday we had guests over at our own house. So by Sunday I was a little better. But when I went to the Eid dinner on Saturday, I was like, oh my God, don't look at me, guys. Like, I'm just here to eat. But yeah, today I'm a little better. Yesterday I couldn't talk at all still. It was really weird that was happening. But I'm okay now. I'm a lot better now. I should be good by tomorrow for sure. But yes, thank you for the support. I really appreciate you guys. Okay, so now, so let's look at this. Galactokinase deficiency. So you have the same display of these enzymes again, right? And you see galactokinase takes galactose, uses ATP, makes galactose 1-phosphate. And then uridyl transferase, you can see over here, there's 4 epimerase doing this thing with UDP galactose and UDP glucose going in a circle. This cycle keeps going with uridyl transferase, ultimately giving you glucose 1-phosphate, right? And then glucose 1-phosphate, we've already looked at before, goes into glycolysis and you're good to go. So you can see from both of these outlines, I guess, how you get something that joins glycolysis, right? With fructose, you get glyceraldehyde 3-phosphate, which goes into glycolysis. And here with galactose, you get glucose 1-phosphate, which is at the tip, very beginning part of glycolysis. This other enzyme here, aldose reductase, is also very, very important. And we're going to see what's up with that soon enough too, because that's the part that's responsible for the cataract stuff. So here we have galactokinase deficiency. So without galactokinase, you're not going to make galactose 1-phosphate. You're not going to trap galactose within cells. But what are you going to do? Well, you're just going to have a lot of galactose floating around, right? And that's going to go this way, because it can't go towards this way anymore. So it's going to go down into galactitol via aldose reductase. Galactitol accumulates, and you get a relatively mild condition in galactokinase deficiency because you're not going to have, like we saw earlier with all the jaundice and all that, but you are going to have infantile cataracts, right? Because galactitol actually leads to cataracts. May present as a failure to track objects or to develop a social smile, which would be given to you in a question. It might tell you that the baby isn't looking at anyone, is not following anything, and is not even smiling when it looks at, when the baby looks at his mom or whatever. So those little things might be a hint for you to understand that the baby probably has cataracts. They won't necessarily tell you straight up, oh, and the infant has cataracts. So galactokinase deficiency is also kinder compared to classic galactosemia, where you have an absence of G1P uridyltransferase, right? Without the uridyltransferase, you've got galactose 1 phosphate that you already made and it's stuck inside cells, so you're losing phosphate. So once again, when you lose phosphate, remember, we already talked about it up here too, without phosphate, decrease in available phosphate leads to inhibition of glycogenolysis and gluconeogenesis. So you would get hypoglycemia, right? And that's going to happen over here as well. Classic galactosemia, you lose all your phosphates, you lose a lot of phosphates, so you will have hypoglycemia. But on top of that, right, you also, so the failure to thrive, jaundice, hepatomegaly, all of this, right? Failure to thrive is mostly coming from hypoglycemia. But then the jaundice, hepatomegaly, infantile cataracts, and intellectual disability, right? Super bad. That's like, we just went from only cataracts to now having intellectual disability. So big jump right there, and that's why the gut part is to remember the more severe condition, which is with uridyltransferase. Can predispose to E. coli sepsis, which is what your question is going to probably be about. Right? This is the special thing about classic galactosemia. I don't think this is the question, is it? No. There is a question later on somewhere where the question was actually about E. coli, right, in classic galactosemia. So you do have to remember every time you see classic galactosemia, remember milk, and then remember E. coli, right? E. coli actually has something to do with milk as well. It has something to do with lactose. So make sure you recall the E. coli sepsis in neonates. Treatment is to just exclude galactose and lactose from the diet, so no more milk for this infant. But that can be pretty troublesome, right? Especially if you've already been feeding milk for a very long time. So definitely watch out for that. Lactose is present not only in breast milk, but also in routine formula. Now, if you look at this question, you see an 11-year-old girl is evaluated for blurry vision. She was adopted internationally at age 9 and has no history of head or eye trauma or exposure to ionizing radiation, which is important to know. Motor and cognitive milestones have been achieved at the appropriate age. She has a good appetite and does not follow any specific diet. She takes no medications and has no allergies. Vaccinations are up to date, vitals are normal, and she's at the 40th percentile for height and weight. Other than bilateral lens opacities, the rest of her exam is normal. Urine is positive for reducing substances. Like I told you earlier, that thing is very nonspecific. Deficient activity of which enzyme is the most likely cause of her condition? Now, this can't have anything to do with fructokinase or fructose urea because we're talking about cataracts here, right? Cataracts go into galactose issues. And then of the two galactose issues, this does not look like the gut issue, the GUT issue, because uridyltransferase deficiency would have more issues than just the cataracts. So this must be a galactokinase deficiency because all she has is the cataracts, all right? And galactokinase is also just known as GALK, G-A-L-K for short. GALK deficiency causes galactose buildup, and this excess is converted to galactitol, an osmotic agent that causes cataracts. Serious systemic manifestations are not seen in GALK deficiency, and cataracts may be the only manifestation. GALK deficiency results in a more serious form of galactosemia, and the GALK part is the uridyltransferase one. So, infants born in the U.S. undergo routine newborn screens for detecting inborn errors of metabolism, such as galactosemia. The fructose metabolism errors do not cause cataracts. Right, so it's very important to learn how to cancel out answer choices, and then there really isn't much to forget once you studied this page a pretty decent amount. You don't have to spend too much time on it. It's really not a difficult page at all. All 4 of these issues are pretty straightforward. Just remember the E. coli sepsis for classic galactosemia. And remember that in fructose urea, in fructokinase deficiency, hexokinase takes over. And then Fab gut helps you remember the more severe condition. The next page starts talking about sorbitol, right? So sorbitol is important because it's also using the same enzyme, aldose reductase. Sorbitol and galactitol are both sugar alcohols in a sense, right? So what do? An alternative method of trapping glucose in the cell is to convert it to its alcohol counterpart, sorbitol, via aldose reductase. Some tissues then convert sorbitol to fructose using sorbitol dehydrogenase. Tissues with an insufficient amount or activity of this enzyme are at a risk of intracellular sorbitol accumulation, causing osmotic damage. Being an osmotic agent basically means it pulls water. Cataracts, retinopathy, and peripheral neuropathy seen with chronic hyperglycemia in diabetes. Right? This is a complication in diabetes that we've seen many times, and it's definitely something that we warn patients about. High blood levels of galactose also result in conversion to the osmotically active galactitol via aldose reductase. So this first part is less important to remember. The liver, ovaries, and seminal vesicles have both enzymes. So they're actually able to deal with sorbitol by making fructose out of it. Sorbitol dehydrogenase is present in them. The one you really need to remember is this part. Lens has primarily aldose reductase. Retina, kidneys, and Schwann cells only have aldose reductase. Right? So the lens has some sorbitol dehydrogenase, but really not enough. And what we're really trying to get at is that the lens, retina, kidneys, and Schwann cells are all going to accumulate sorbitol. Alright? And if you're going to accumulate sorbitol in all four of these guys, then these are all the guys that are pretty much what we care about when we have uncontrolled, uncontrolled diabetes, right? You get peripheral neuropathy, you damage your Schwann cells, you get kidney injury, and you get cataracts. So glaucoma as well, which is going to follow. So the lurks part is the very important part to remember to really understand where you're going to have an accumulation of sorbitol and galactitol. And that's really all they talk about right there. Lactase deficiency is really not that big of a deal. It's pretty much something you can deal with by just taking lactase pills. Right? They tell you that here treatment, avoid dairy products, or if you must have dairy products, maybe it's your birthday, you need to have cake or something, add lactase pills to the diet, all right, and use lactose-free milk wherever possible. So what is lactase deficiency? It's insufficient lactase enzyme, which leads to dietary lactose intolerance. Lactase functions on the intestinal brush border to digest lactose in milk and milk products. It breaks lactose down to glucose and galactose. Primary lactase deficiency is age-dependent. It's an age-dependent decline after childhood, and it just happens. It's pretty common in Asian, African, and Native American descent people. So most people that I know that are lactase deficient are actually Asian. They're all like Chinese or Korean, something like that. I don't know anyone that's either Indian or Bengali that's lactase deficient, but I guess there's definitely validity to this statement. Why it happens, no one truly understands. That's just the genetics to it. Secondary lactase deficiency is loss of the intestinal brush border due to gastroenteritis. So that means that you didn't lose the enzyme. Right? Primary one is actually losing the enzyme. Secondary is losing something else that doesn't allow the enzyme to do its work. And remember, lactase actually functions at the intestinal brush border. So secondary lactase deficiency is where the brush border isn't working because of some kind of viral gastroenteritis or autoimmune disease of your intestinal brush border. So then your lactase isn't going to work anymore. The last one here is congenital lactase deficiency, which is rare, but it's just due to a genetic thing. If you do a stool test, then you'll see there's a very low pH, right? So acidic stool. And the breath shows high hydrogen content with lactose hydrogen breath test, both of which are things that can be mentioned in a question. Intestinal biopsy reveals normal mucosa in patients with hereditary lactose intolerance. Right? Remember, lactase deficiency is just missing enzyme. Has nothing to do with the mucosa. Secondary lactase deficiency would be a whole different thing where you would have mucosal damage, but that's not because of the lactase or related to lactase, it's because of the gastroenteritis. The last thing on this page is the amino acids you have to memorize. Now, you do have to know these. It's very important to know them. You're not going to memorize them on your first time, but I feel like the memorization tools that First Aid provides here are more than enough to actually memorize them. So your essential amino acids are broken down into glucogenic, mixed, or ketogenic. We already talked about the ketogenic ones earlier when we looked at PDH deficiency, where a patient who doesn't have pyruvate dehydrogenase cannot do glycolysis of the glucogenic amino acids. So you get them ketogenic amino acids, which don't require you to do anything glucogenic at all. And those were leucine and lysine. Right? So leucine and lysine are purely ketogenic. All right, great. That's easy. The glucogenic ones are easy as well because I love the I met his Valentine, she is so sweet. Met his Valentine is all you really need to remember. It reminds you of methionine, histidine, and valine. Those are the only ones that are purely glucogenic. The mixed ones, glucogenic and ketogenic, are isoleucine, phenylalanine, threonine, and tryptophan. Now, how you memorize them or whether you even do memorize them is completely up to you. But it's actually pretty easy because none of these guys are ever going to show up anywhere else again, right? So there's no, like threonine and tryptophan are not acidic. Threonine and tryptophan are not basic. Okay, so they don't show up here either. And isoleucine and phenylalanine, I always look at them as two, like those are the amino acids that have two names to it. So isoleucine has the iso and leucine, and the phenylalanine has the phenyl and alanine. Alright, so that's that. And then the threonine and tryptophan, just the T's, they're the only ones that have T's to it. Really, it's not really like a mnemonic or anything, but it helped me just to look at it like that and like set them aside from everyone else. The acidic ones are always going to be the ones that end in an ate, right? Like lactate, for example, is lactic acid. So when the amino acids come down, you have aspartate and glutamate, or aspartic acid and glutamic acid, same thing. Those two are obviously acidic, right? So they're going to have a low pH. And not only are they going to have a low pH, but they're also negatively charged at body pH. Right? So those are your acidic guys. The basic guys, there's arginine, histidine, and lysine. And this statement of his lies are basic is also equally as genius as his Valentine for remembering the basic amino acids. All right? So glucogenic, which means really sweet. Met his Valentine, she's so sweet. Methionine, histidine, valine. Leucine and lysine are the only ones that are ketogenic. His lies are basic are the ones that are all basic. And then the acidic ones are the ones that have acid in their name. Super straightforward. So at the end of the day, memorizing all of this is actually really easy. Okay. Arginine is the most basic. Histidine has no charge at body pH. Arginine and histidine are required during periods of growth. And arginine and lysine are high in histones, which bind negatively charged DNA. And we talked about that already, right? We had that way in the beginning on the first page of biochemistry. I made up that word large, where the L was red and the ARG was blue, to remind you of lysine and arginine. Okay? And where are we right now? We're on page 81. Okay, let's just go back to it real quick. So right here, lysine and arginine, large. Okay? So that's really important, and lysine especially was more important even than arginine, because lysines were the ones that would be regulated by covalently adding or removing methyl acetyl groups from muting or activating, etc., right? So we already talked about all that part, and that's really it for that. Now this is a pretty interesting question here from UWorld. A lot of people got it wrong, so well, actually 76% of people got it right in UWorld. But a lot of the people that I worked with and taught this to or worked with this question with, they were pretty lost. So let's look at it. Succinate dehydrogenase is an enzyme complex within the inner mitochondrial membrane, and it catalyzes the oxidation of succinate to fumarate. An experiment is conducted to determine if malate alters the rate of SDH activity. Reaction velocity is measured with and without a fixed quantity of malate as succinate concentration is gradually increased. Obtained results are as follows, and then that table is given. What is the most accurate statement about malate in this experiment? Now, malate is pretty important, and so is succinate dehydrogenase. We've pretty much seen that happening throughout so far in all the videos up to now, and we've talked about them a lot of times. So before even looking at like the acid choices and stuff, you should really see what's happening with the numbers here. So they give you a succinate concentration, the rate of reaction without malate, and the rate of reaction with malate. And succinate concentration looks like it's increasing by powers of 2. So 2 squared, 2 cubed, 2 to the 4th, and so on. Rate of reaction without malate, 80, 200, 280, 400, 400. So it looks like it reached a maximum. Rate of reaction with malate, 40, which is actually half of that, 120, 200, and then 400, 400. So they both reached a maximum, but rate of reaction with malate was a little slower. And succinate concentration seems to be increasing exponentially, right? That's what it means to say if it's increasing by powers of 2s. So what's happening? The most accurate statement about the malate in this experiment. So Answer A was it alters the maximal velocity of the reaction. Clearly not true, right? Like this should have been 0% of people because the maximal velocity is 400 in both of them. It binds the enzyme at a different site than succinate. All right, so that's binding at a different site than succinate would be a competition, but it would be non-competitive, right? Non-competitive. So let's assume for a second that's a possible answer choice. It covalently binds the enzyme. That's not a possible answer choice at all. Covalently binding the enzyme would actually be a very powerful thing. The rate of reaction with malate would actually not even increase as quick. It would just be like very, very slow. The enzyme wouldn't work, basically. It decreases affinity of the enzyme for succinate. So decreasing affinity basically means increasing Km, right? If you increase Km, and if you haven't done the pharmacology stuff yet, then this question should still be something you could solve, but knowing that decreasing affinity, which just means increasing Km, if you increase Km, then remember Km is equal to half of Vmax. If you increase Km, you also increase half of Vmax. So you would be achieving your Vmax, at a pretty decent time as well, but it doesn't happen. You're achieving Vmax even slower, right? So if you're achieving Vmax slower, I can see why 10% of people chose this answer choice, because decreasing affinity of the enzyme, a lot of people equate that to mean the same thing as the enzyme didn't grab the substrate, but that's not what's happening here. The affinity an enzyme has for its substrate almost never changes, right? It's just that there's another substrate here now that looks very much like the substrate it wants to get, so it's grabbing that. And that answer choice is E. It is a competitive inhibitor of the enzyme, right? Competitive inhibitor. Because what happens is when succinate concentration was low, right, the rate of reaction was low. But as I increased succinate concentration, I was able to reach maximum rate of reaction, even with the malate there, right? The fact that this is being shown on this graph confirms that this has to be a competitive inhibitor. If it was covalently binding, then increasing succinate concentration would have no effect on the rate of reaction. It just wouldn't work either way. It doesn't matter how much of the right substrate you have, your reaction is not going to work. And decreases affinity of the enzyme for succinate, that's not how competition really works to begin with. And the explanation here just goes on to talk to you about that. So, feel free to read it if you want, but that's generally all you really need to know. Just make sure when you get questions like this that you do take your time. Remember, on step 1, believe it or not, you have more than enough time to get through all the questions in a given block. So don't rush and don't really waste too much time looking at a clock either. Because if you look at the clock, you kind of looked away from the question, and then you'll have to reread the whole question again. And that's a very common thing. Urea cycle. So first aid doesn't really teach much about the urea cycle. There's a lot more written here that you kind of have to delve into. If you're just looking at the urea cycle, this is one of the hug guys. So this is one of the cycles that takes place in both the mitochondria as well as the cytoplasm. Right, so this is the U in hug. It starts with carbonyl phosphate synthetase 1, CPS1. Remember, CPS2 was what we looked at earlier in molecular for pyrimidine and purine synthesis and all that stuff, specifically for pyrimidine synthesis, right? CPS1 is the one over here in the urea cycle. Okay, so what's happening here? You have CPS1 that works with an allosteric activator N-acetylglutamate to take CO2 and CO2 and ammonia to make carbonyl phosphate, right? And then that carbonyl phosphate works with ornithine transcarbamylase to make citrulline. And then you go out into the cytoplasm, you do everything, and ultimately you have urea formed thanks to arginase, right? Arginase takes arginine, makes urea, which goes to the kidney, and you're going to urinate that. That's why this is the urea cycle. And you make ornithine, which goes back into the mitochondria again for ornithine transcarbamylase to do its job. So that's the whole cycle right there. Now, where can things go wrong? The rate-limiting step of CPS1 is right here with the carbonyl phosphate synthetase. And, the rate-limiting step of urea cycle is CPS1. And that's also regulated by N-acetylglutamate. N-acetylglutamate is actually made by another enzyme called N-acetylglutamate synthase, NAGS, and this step is inhibited. Oh, okay, without NAGS. If this step is inhibited, basically, if this step is inhibited, or if CPS1 isn't working, either one of those things, if you're not making an N-acetylglutamate, or if your CPS1 enzyme is not working, you're going to accumulate this ammonia, right? This ammonia is going to accumulate in your mitochondria, in your serum, basically, and you're going to get type 1 hyperammonemia, right? Type 1 hyperammonemia is a deficiency of CPS1 function. N-acetylglutamate is made of acetyl-CoA and glutamate. That's something you can get a silly question on. So it's good to have heard that here. You might not get a question on it at all. But, don't waste too much time trying to memorize this. It's really not the most important thing on earth. But it's nice to at least have heard it once. So N-acetylglutamate is actually made of acetyl-CoA and glutamate. NAGS deficiency is autosomal recessive, as is CPS1 deficiency, right? Both of those are autosomal recessive. If you have those deficiencies, then the infant presents with lethargy, breathing and temperature fluctuations, plus seizures because of the hyperammonemia. Both have low carbonyl phosphate and no orotate in the urine. All right, that's very important to remember for your differentials that you have to do. So if you look at, we're gonna see it later on, but okay, right here, right? So we just talked about this part right here. With either of these guys not working, you're gonna have low carbonyl phosphate because you're not gonna make any carbonyl phosphate, and you're gonna have no orotate in the urine. But if you have OTC deficiency, ornithine transcarbamylase deficiency, which is this enzyme, that has excess carbonyl phosphate because you'll make carbonyl phosphate, but you're not gonna use it on the next step to make citrulline. And that excess carbonyl phosphate actually stimulates pyrimidine synthesis, where you have the CPS2 enzyme, right? And that pyrimidine synthesis leads to increased urinary orotate or orotic acid, right? And then you get orotic aciduria. That's a whole different disease. But that is a disease that is one of the differentials of OTC deficiency, ornithine transcarbamylase deficiency. Over here, down here is another thing from UWorld. UWorld had a question on arginase deficiency, where they talked about urea cycle. They talked about a patient presenting with similar symptoms of urea cycle deficiency, but you could tell that it wasn't CPS1 deficiency or OTC deficiency because the patient had no hyperammonemia. You see this last sentence. Unlike other urea cycle disorders, patients with arginase deficiency have mild or no hyperammonemia. So if you get a question on a patient who, the question seems to be talking about urea cycle, the question seems to be talking about a patient who's having symptoms of urea cycle disorders, but they don't have hyperammonemia, don't fall for the trick. Just understand that it's arginase deficiency, which is very important. It's more significant than the other guys. There's no issues or questions on this one and this one, but you will have arginase deficiency as something you need to learn, because this is the essential step that actually makes urea in the end. And in arginase deficiency, you don't have hyperammonemia because you've already used your ammonia, you made CP, you made citrulline, it's already been broken down and stuff. Alright, so that's literally all there is to talk about here. If you see the fumarate, you can obviously think that every time fumarate is made here, this fumarate will be fed into the TCA cycle, and that's it. Okay, so that's literally all you need to know for urea cycle. Now, the diseases, OTC deficiency, ornithine transcarbamylase deficiency, as well as orotic aciduria, those are two times that you're going to have to make sure you don't confuse the issues with urea cycle, or is it a pyrimidine synthesis issue. And arginase deficiency is going to make you be confused with the orotic aciduria as well, because orotic aciduria also doesn't have hyperammonemia. So we're going to get there. So obviously they're going to start talking about hyperammonemia, but before we get there, here in the middle, they talk about transport of ammonia by alanine. Right, so we've talked about the alanine issue. We talked about alanine quite a bit because alanine was actually inhibiting some steps when we were doing glycolysis, right? And we also talked about how alanine was one of the pathways, thanks to alanine transferase, for where pyruvate would be shunted if you're not doing glycolysis. Right, so if you forgot, let's go back and take a look at that, because repetition is one of the best ways to memorize shit. Okay. So when we were right here in glycolysis, you can see alanine right here. Alanine inhibits pyruvate kinase activity. So if you have a lot of alanine, you're not going to keep going ahead with glycolysis. And why are we doing that? Why is alanine stopping glycolysis? Well, that's because alanine, right? Alanine accumulating is actually a sign that your pyruvate dehydrogenase complex is not doing its job, right? If pyruvate dehydrogenase is not doing its job, you're not going to take pyruvate to acetyl-CoA. That means that you're accumulating pyruvate. That accumulated pyruvate actually gets sent into being made into alanine, which is part of the Cahill cycle. You're not going to go over here. You're not going to go to the lactate and go into Cori cycle because that requires NADH. All right, so that would be in alcoholic patients. In alcoholic patients, they don't have any NAD+, so they cannot do this pathway. But they have a lot of NADH, so they go ahead and do this pathway, and they have lactic acidosis. In normal patients who just don't have pyruvate dehydrogenase, right, they cannot go this way, so they go this way, and they make a bunch of alanine. Making a lot of alanine is one of the issues that you see, right? Pyruvate dehydrogenase complex deficiency causes a buildup of pyruvate, and that pyruvate gets shunted to lactate and alanine, but mostly alanine. And that alanine, when it's accumulating, comes back and inhibits you from making more pyruvate, which is done by pyruvate kinase. Right? It's very important to understand that because that's the basic shit you'll get questions on, right? So now we're looking at the Cahill cycle. You can see the Cahill cycle with the blue highlight, and in the middle in the yellow is the Cori cycle. And since I'm still sick, I keep getting like extremely dry when I try talking. It's so weird. So the Cahill cycle isn't just about alanine per se. It's also the main form of actually moving around ammonia. Because remember, ammonia, since the urea cycle only occurs in the liver, the ammonia made in muscle and other places of the body must be transported to the liver. This is accomplished in the form of alanine. The alpha-ketoglutarate is the same one from TCA cycle. You can see the alpha-ketoglutarate right here in the muscle and right here in the liver. The making of alanine is catalyzed by alanine aminotransferase, which is one of the liver enzymes that you look at when you're evaluating someone's liver health. And the alanine here enters the Cahill cycle, which is the blue part. So you can see it starts over here. You have amino acids, which are giving you ammonia. The ammonia are broken into alpha-keto acids and mixed with alpha-ketoglutarate to make glutamate. And glutamate is how you shunt ammonia around the body, right? That glutamate will become alanine by mixing with pyruvate, right? And you're going to be doing a lot of this with your pyruvate if you have nothing else to do with it, and also because you need to move around ammonia if there's a lot of ammonia. That pyruvate gave you alanine. Now your alanine can go through your Cahill cycle, reach the liver, successfully bringing ammonia into the liver from wherever in the body. In this example, it's the muscle. Excuse me. And then that alanine now reconverts back to glutamate. This is so bad. Back to glutamate, and you get your urea. Okay. And this is why I haven't been live for the past 2 days, because anytime I try talking, this starts happening. Alright, so what is the Cori cycle about, right? Because we can see the Cahill cycle just did everything by itself. Where's the Cori cycle involved? The Cori cycle is the other thing that pyruvate does. Remember, we already talked about pyruvate going to alanine, but the other thing it did was pyruvate going to lactate, right? And that's the Cori cycle. So if you get a silly question on the Cori cycle, you want to make sure you know what you're talking about, and you want to make sure that the answer choice Cori cycle doesn't look very alien to you. It doesn't want to be like the weirdest thing to you, right? You should know what the Cori cycle is, and that's the cycle that takes lactate from muscle and brings it back to the liver. The Cori cycle refers to the metabolic pathway in which lactate produced by anaerobic glycolysis in the muscles moves to the liver and is converted to glucose, which then returns to the muscles and is metabolized back to lactate. Okay, so that's all this little portion in the middle is about. And then the last thing on this page is about hyperammonemia, which can be acquired or hereditary. Now, acquired hyperammonemia is always going to be about liver disease, and you can get all kinds of GIT questions where you're going to see hyperammonemia. But the hereditary hyperammonemia is going to be due to deficiency of CPS1 or your N-acetylglutamate synthase. And if this keeps up, I'll just end the live session. Sorry, guys. Alright, so it can be acquired or hereditary. It presents with flapping tremor, which honestly won't be in most of the questions. Right, this asterisk thing, you're probably not going to get that in the question because it's usually a giveaway. You also have slurring of speech, somnolence, which is just excessive sleepiness. So they'll describe a baby who just keeps falling asleep or sleeps too much. Vomiting, cerebral edema, and blurring of vision, mostly because of weakness, not because of any kind of glucose issue. High ammonia depletes glutamate in the CNS, and that inhibits the TCA cycle, which leads to decreased alpha-ketoglutarate. And all of this is exactly what was explained up here. If you have a lot of ammonia, because you start here, right? You start the transport of ammonia by alanine. So if you have high ammonia, as in hyperammonemia, if you have a lot of ammonia, you're going to use all your alpha-ketoglutarate to make glutamate. All right? So if you lost alpha-ketoglutarate, you can no longer do TCA cycle. Then all your glutamate is going to become alanine. If you lost glutamate, then you don't have any more glutamate in the CNS. And glutamate is supposedly inhibitory, right? So now you see over here alpha-ketoglutarate, glutamate, glutamine. Without glutamate, you can't make GABA, and GABA is inhibitory. Okay. Also remember, making GABA requires B6, which is pyridoxine. I remember pyridoxine was, when we talked about vitamins, pyridoxine was one of the vitamins that had a multi-system effect. So there was no clinical picture for B6 deficiency. Excuse me. So before we look at treatment, let's keep looking at more of the shit that you need to know. In conditions of hyperammonemia, glutamate becomes the limiting factor and is compensated by amination of alpha-ketoglutarate to form more glutamate through glutamate dehydrogenase. The glutamate then combines with more ammonia to make even more glutamine. Right, that's the glutamine down here, the last thing. So you see how you're using up all your ammonia? In hyperammonemia, you need to use up all your ammonia, so you keep doing steps that require more and more ammonia. And if you use up all your ammonia because you don't want to have hyperammonemia, you essentially just end up making a lot of glutamine. You run out of glutamate and you run out of alpha-ketoglutarate, so you don't have any TCA and you don't have any inhibitory GABA. That is the essential full pathophysiology of hyperammonemia. So now, glutamate becoming alpha-ketoglutarate is a reversible reaction favored based on the NAD plus and NADH ratio. In normal health, there is more NAD plus. Remember, the plus is a sign for you to understand that NAD plus is the good guy and you want more of it. But in hyperammonemia and in alcoholism, we prefer the reverse formation of glutamate, leading to excitotoxicity. Okay, and alcoholics, there isn't much NAD plus, so you end up going the other way and making more making more of the glutamate. So what's the takeaway from here? That in a patient with hyperammonemia, you should expect high glutamine, right? High glutamine. They're gonna have low glutamate, low GABA, and low alpha-ketoglutarate. They're gonna have high glutamine, and that can be a question in itself, where you have the up and down arrows, and they'll ask you, what would you expect in this patient, blah blah blah. So what is the treatment? Treatment is to limit protein in the diet, right? Because most of your ammonia comes from amino acids. So if you decrease protein intake, you decrease the amount of ammonia you can possibly make. Maybe these are things that you can give to someone to decrease ammonia levels. So these are your other acid choices that you can have. Lactulose. Lactulose actually acidifies the GI tract. So it brings more H pluses to the GI tract. Those H pluses can combine with ammonia to make ammonium. Ammonium being the bigger word, it's longer than ammonia. Ammonium is NH4 plus. Okay, and this thing gets excreted. It cannot cross the GI epithelium, so you don't get hyperammonemia anymore. You just excrete all your ammonium. You can also give antibiotics like rifaximin or neomycin to decrease ammonia-genic bacteria. Not the most effective way of dealing with this, but again, another thing you can do. Benzoate, phenylacetate, or phenylbutyrate react with glycine or glutamine, forming products that are excreted renally. These would be things you would give to get rid of the glutamine. But by that point, you've got some issues already, right? Because by that point, you've used up all your glutamate, you've lost all your alpha-ketoglutarate, so you have no more TCA, you have no more GABA, and you don't want that to happen. Now look at these two questions. So this first one came from a random place. I was just doing some research on what the hell do I need to know about hyperammonemia. This one says a newborn becomes progressively lethargic after feeding. His respiratory rate increases and he becomes virtually comatose, responding only to painful stimuli, and exhibits mild respiratory alkalosis. A urea cycle disorder is suspected and evaluation of serum amino acids levels is initiated. In the presence of hyperammonemia, what amino acid is always increased? So literally this entire story was unnecessary. They could have just asked you this question. And the answer to that question is glutamine, right? Anytime you have a patient with hyperammonemia, all their ammonia is going to combine with all these guys so that you can use up your ammonia and you're going to make glutamine. So you're going to have high glutamine. That's it. This next question also has a similar kind of thing. This is from UWorld though. So a 54-year-old man with a history of cirrhosis is brought to the emergency department by his wife, who found him agitated and confused. She says he was nauseous and vomited bright red blood several times yesterday. His cirrhosis is secondary to chronic hepatitis C infection, and he has received treatment for esophageal varices in the past. Physical exam reveals abdominal distension, decreased liver span, and testicular atrophy. A jerky, irregular tremor involving his hands is seen with wrist extension, which is asterixis. What is most likely to be elevated in his astrocytes? And the answer again is glutamine, right? But now the question was what's going to be elevated in astrocytes, and this question had a picture associated with it, which is this question right, this image right here. All right, so in this picture, what do you see? You see cerebral capillary. This itself is a swollen astrocyte. You have your presynaptic neuron and a postsynaptic neuron. All right, so in your blood, you're seeing ammonia. That ammonia is getting taken up by a swollen astrocyte. In here, you have the accumulation of glutamine, right? Because the ammonia is being made into glutamine by glutamine synthetase. That's the enzyme responsible for this step right here. Glutamate becoming glutamine is being done by glutamine synthetase, right? So this is where the ammonia came from. Where did the glutamate come from? The glutamate came from the presynaptic neuron, right? In between the presynaptic and postsynaptic neuron, in your presynaptic neuron, you release glutamate, and that's supposed to go to your postsynaptic neuron and do something, but it won't even reach. Essentially not doing anything, right? Because your astrocyte is going to take it up to combine it with ammonia and make glutamine. Now, in your presynaptic neuron, you have another enzyme called glutaminase, which can actually break glutamine back to glutamate again, but then that's not really going to help too much because you're not just breaking it into glutamate, you're breaking it into glutamate and ammonia. So continuing the hyperammonemia that you're supposed to have. The question goes on to tell you that he clearly has hepatic encephalopathy, likely due to his recent GI bleeding, causing a corresponding increase in nitrogen absorption by the gut. And that's something you have to remember for all questions about that. That's a very important pathophysiology. If you get a question with GI bleeding, then you have to understand there's going to be an increase in nitrogen absorption, and that nitrogen absorption is going to lead to hyperammonemia. Okay, very important to remember that. It's something that can happen to anyone. The pathogenesis of hepatic encephalopathy is discussed on page 424, and is related to increased circulatory levels of ammonia and other neurotoxins due to failure of the liver to metabolize waste products. The image of hyperammonemia is on the next page. So hepatic encephalopathy is discussed in GIT, and you'll see that when we get there. But this question did point out a lot of symptoms of hepatic encephalopathy. They pointed out the testicular atrophy, decreased liver span, right, and abdominal distension, as well as his asterixis. And there's an entire body shape thing that happens. Let me see if we can find it actually. Is it still this page? It is that page, but I'm trying to find the... No, that's not the image that I wanted to see. Yeah, this image right here. Right, so this guy is exactly what we're kind of looking at when we look at the patient in that question. Right, this guy, you can see reproductive is testicular atrophy right here. He had the esophageal varices. They mentioned that in the question as well. He was vomiting bright red blood. Right, he would have a lot of these other symptoms as well, because that's exactly what his issue was. And yeah, hepatic encephalopathy is a pretty bad problem. Okay, hepatic encephalopathy right here. Cirrhosis leads to portosystemic shunts, which has decreased ammonia metabolism, so you get hyperammonemia because you're not metabolizing the ammonia. You get neuropsychiatric dysfunction, reversible neuropsychiatric dysfunction ranging from disorientation and asterixis to difficult arousal or even a coma. He had disorientation and asterixis. That's why he was lost. Triggers are high ammonia production or decreased ammonia removal. And the treatments are the same things we looked at earlier. Okay? Oh, and this is another question about hyperammonemia once again, but the answer is just glutamine. Right? This is also related to GI issues. Remember, you're very likely to get a GI issue as a question, but the question is actually about hyperammonemia. So here you have a 68-year-old man that comes to the emergency room due to abdominal pain and nausea for the past 2 days. He has a history of atherosclerotic cardiovascular disease and underwent coronary artery bypass surgery 2 years ago. Blood pressure is 105/65, heart rate's 120, which is very high, and irregular. Abdominal exam reveals mild diffuse tenderness and decreased bowel sounds. Lab studies are as follows. Sodium chloride and all that is given. You have your bicarb, creatinine, pH, PaCO2, high lactic acid. So you can kind of see that he has acidosis going on. ECG shows absent P waves and an irregular rate and rhythm, so he's got some kind of fibrillation as well. Atrial fibrillation. CT scan of the abdomen reveals colonic wall thickening and no enhancement with IV contrast. Now that tells you a lot, right? If colonic wall thickening is always a sign of inflammation, because anytime you have inflammation anywhere or trauma on any kind of part of your body, it will swell up, and that's what colonic wall thickening is about. But the no enhancement with IV contrast tells you another thing. Urinalysis shows acidic urine. Renal metabolism of what amino acid is most important for maximizing acid excretion in this patient? And the answer was glutamine. So you see how this question, the final sentence, is worded very differently from the previous two. And glutamine was in the answer choices, you would just pick it because you need to understand that something's wrong with his GI system. He has some kind of GI bleed for sure. And he does. The lack of IV contrast actually tells you that this patient has acute ischemic colitis, which is most likely due to an embolic disease related to his AFib. Right? He has atrial fibrillation. He has atherosclerotic cardiovascular disease. So he must have had some kind of atherosclerotic embolus that's traveling, and it got stuck somewhere in his GI system, caused GI ischemic colitis, and then boom, now he's presenting with hyperammonemia. Ammonium ions are transported into the... acidosis stimulates renal ammoniogenesis. Another statement very important to remember. Acidosis stimulates renal ammoniogenesis, a process by which renal epithelial cells metabolize glutamine, generating ammonium and bicarbonate. Ammonium ions are transported into the tubular fluid and excreted, which is a good thing, while peritubular capillaries absorb bicarbonate, which functions to buffer acids in the blood. So both of these things happening are a good thing. This is something your body is doing to get rid of the hyperammonemia and fix the acidosis. But you do end up having other symptoms of hyperammonemia because you used up all your glutamate, so you don't have any more GABA, and you used up all your alpha-ketoglutarate, the AKG. You used up all your alpha-ketoglutarate right here, so you can't do TCA cycle. And that is a lot of the hyperammonemia bullshit you need to know. Very important to get all that correctly. We talked about OTC deficiency from the urea cycle, right? This is the most common urea cycle disorder. And there's a lot of differentials you have to keep in mind with this. So OTC deficiency, most common urea cycle disorder. Not only that, it's also X-linked recessive, which makes it a little special in terms of genetics. Other urea cycle enzyme deficiencies were autosomal recessive, and we saw that, right? I told you guys that NAGS, N-acetylglutamate synthase deficiency, is autosomal recessive. caramel phosphate synthetase deficiency is autosomal recessive. But here we're looking at OTC deficiency, which is in the mitochondria still, right here. Takes ornithine, makes citrulline. That enzyme is deficient, X-linked recessive. Interferes with the body's ability to eliminate ammonia. Often evident in the first few days of life, but may present later. Excess caramel phosphate is converted to orotic acid, which is part of the pyrimidine synthesis pathway from earlier. Findings are going to be high orotic acid in the blood and urine, low BUN, and symptoms of hyperammonemia. But you're not going to have megaloblastic anemia. And I think earlier I said orotic aciduria has no hyperammonemia. It does. But I meant it has no megaloblastic anemia. My bad about that. But let's take a look at orotic aciduria as well, which is on page 452. So, page 452. Make this red. Page numbers are usually red. Okay. So page 452 is where you have orotic aciduria, which I believe is in your anemias. Yeah. Okay, so right here, orotic aciduria. That is a very simple disease. It's simply the inability to convert orotic acid to UMP, which is actually happening. We saw it already in biochemistry when we looked at de novo pyrimidine synthesis pathway. You need to make UMP to continue going and making thymine and all that. So we'll go back and look at that too. And this is all because of a deficiency or a defect in UMP synthase, a different enzyme, right? It's also autosomal recessive, and it presents in children as a failure to thrive, developmental delay, and megaloblastic anemia, which is refractory to folate and B12. Right? So you got a baby who you gave folate, you gave B12, still has ammonia. Still has megaloblastic anemia. And I was right. There is no hyperammonemia here. Right? And that's because you're actually doing the urea cycle. The urea cycle is working just fine. So there's no hyperammonemia here, but you have megaloblastic anemia. So there's a lot of little things that you have to know to get the differentials correct there, right? And don't doubt yourself like I just did right now. My excuse is I'm sick. I'm going to use that as an excuse for any stupid mistakes I make here. But really, it wasn't a mistake at all. I was right. I was just doubting myself. Right? So no hyperammonemia in orotic aciduria because your actual urea cycle itself is working fine. Your CPS1 is working fine. Your N-acetylglutamate is working fine. So you're going to take your ammonia and CO2 and you're going to make your what did they become? Ornithine, right? You're going to make your ornithine. But the ornithine here you're having an issue with is here the issue is with a whole different issue of orotic acid, right? Because you're accumulating a bunch of orotic acid and you cannot convert it to anything else. So you have orotic aciduria. So this is a very simple disease, very straightforward. Always going to present in a question where a child is having difficulty surviving, difficulty thriving or whatever, developmental delay, etc., etc. But they're going to really key in on the megaloblastic anemia not being fixed with folate or B12, right? And the solution is very straightforward too. Treatment is just giving UMP. Like, you don't have any UMP, so you give them uridine monophosphate. That's it. Or uridine triacetate or any kind of uridine, whatever the answer choice you want to pick is, and that's it, right? This UO question does that, and this is generally how you're going to have questions on orotic aciduria. So it says a 14-month boy, right, is evaluated for failure to thrive and developmental delay. His mother reports that at 12 months, he could barely lift his head and had difficulty sitting unsupported. He has not started babbling or forming words. He's at the 10th percentile for height and 5th for weight. Labs show hemoglobin of 8.6, MCV of 114, and reticulocytes are 1%. Plasma ammonia is normal, right? It's 42, supposed to be between 40 to 80. Urine specimens contain large amounts of orotic acid crystals, which literally is a giveaway for orotic aciduria. On NBME or even on your actual step 1, this sentence might not even be given to you because you don't need it. And supplementation with what substance will benefit this patient? And the answer is just uridine, right? UMP, UTP, whatever, you have to give them uridine. He has hereditary orotic aciduria resulting in symptoms seen. That's it. What are the symptoms? Megaloblastic anemia, developmental delay. That's it. Okay. Very straightforward. No hyperammonemia because you're doing this right here, right? Sorry, it makes caramel phosphate, not ornithine. right? So obviously, because CPS, carbophosphate synthetase. So you once you do this step, you're not gonna have hyperammonemia anymore. It's only if this step isn't working that you never used your ammonia, so you end up having hyperammonemia, right? You combine your CO2 with NH3, you make carbophosphate, boom. Now you're not gonna have hyperammonemia. This carbophosphate has to become citrulline thanks to OTC. That's a whole different thing. We talked about that right here. If you have OTC deficiency, you're going to have carbophosphate accumulating. This carbophosphate will get sent into, now let's go take a look at that right here. It'll get sent into right here, see, in the pyrimidine base production, de novo pyrimidine synthesis, carbophosphate. Here in pyrimidine production, carbophosphate was being made by CPS2, a different enzyme, and this enzyme was making it with glutamine and CO2. But in urea cycle, carbophosphate was being made by CPS1 in the mitochondria, right? That's your urea cycle. CPS1 by using CO2 and ammonia, okay? But, however, in mitochondria, if your urea cycle progressed and you made carbophosphate but you have OTC deficiency, all that carbophosphate gets shunted to your pyrimidine synthesis, and the next step here is to take carbophosphate and make orotic acid. Right? But this orotic acid is going to be extra orotic acid. It's going to accumulate, and that's what's happening in OTC deficiency. In orotic aciduria, however, the issue has nothing to do with urea cycle whatsoever. It's actually a deficiency of this enzyme right here, which is called UMP synthase. It takes orotic acid and makes UMP. If you don't make UMP, you can't make your thymine and cytosine. Neither of those guys. And that's problematic. You can't make pyrimidines, so you can't do DNA replication and a bunch of other stuff, right? So you have to give them uridine because they can't make it. So two completely different cycles, completely different diseases, but you can see the overlap and how they're related, all right? So that's urea cycle, that's hyperammonemia. Amino acid derivatives. We got a glimpse of this earlier when we were doing nutrition, and we looked at all the different vitamins and what happens with their deficiencies. And we said that B6 was problematic because B6 deficiency was all over the place, right? So we already looked at just now glutamate becoming GABA requires B6, okay? We're also seeing glycine becoming porphyrin for heme synthesis requires B6. Histidine becoming histamine requires B6. Making serotonin, which then becomes melatonin for sleep, also requires B6. Making niacin, which then goes ahead and becomes NAD+, which is the good guy, also requires B6. And then all the way up here, dopa becoming dopamine, which then gives you norepinephrine, and epinephrine also requires B6. So a question on pyridoxine deficiency can be about any of these guys, right? And you can have multiple symptoms in a patient that seem very unrelated, but they're actually related to vitamin B6. The other thing here is BH4, tetrahydrobiopterin, right? BH4 is required for phenylalanine to become tyrosine, and then again for tyrosine to become dopa, right? And that's going to be pretty important in what we're about to see on the next page. The other places where BH4 are needed are here, for tryptophan to become serotonin, and for arginine. Remember the arginine then became urea. Arginine also becomes nitric oxide in your blood vessels, okay? That also requires BH4. So arginine is pretty important. It's also one of the, remember from earlier, right here, arginine, right? It's also one of the basic amino acids, all right? And the last thing I want to mention from here is, well, two things. One, the BH4 part is going to be what's going to help you understand the difference between just normal PKU, right? Right here, phenylketonuria, just normal PKU versus malignant PKU, right? Malignant PKU is actually a deficiency of BH4, which is really bad because if you just have normal PKU, you can usually give them more. Remember right here, decreased phenylalanine hydroxylase, right? So you don't have phenylalanine becoming, let me see. Yeah, you can just give them tyrosine, right? And then they'll be okay because their phenylalanine is not becoming tyrosine. They don't have phenylalanine hydroxylase activity. You can just give them tyrosine. But if you have a lack of BH4, then even giving tyrosine won't help. So that's one thing. The other thing I want to point out is over here, we've talked about tryptophan earlier. If you have that disease where you make too much serotonin, right, then you run out of tryptophan and you cannot make niacin anymore, and that's going to present really badly. Right, so a lot of little key things that we've already talked about from earlier are coming to terms and making sense now when you look at this entire graph. This other graph down here talks about catecholamine synthesis and tyrosine catabolism. So it's basically taking a closer look at this first row up here. And that's where we're going to get our diseases from on the next page. So let's take a look. Phenylalanine became tyrosine thanks to phenylalanine hydroxylase. If you don't have that, you get PKU. Then you have tyrosine hydroxylase, which makes DOPA. DOPA becomes melanin thanks to the enzyme tyrosinase. If you don't have tyrosinase, you get albinism. DOPA decarboxylase is the enzyme we target with carbidopa in Parkinson patients. Dopamine breakdown, in any case, dopamine breakdown gives you HVA, homovanillic acid. Anytime you see excess HVA, you want to think of a patient who has excess dopamine breakdown. Norepinephrine and epinephrine breakdown gives you VMA, right? You can see vanillyl mandelic acid. Big difference there, right? Two other little guys that are mentioned here are COMT, and you can see COMT doing its job breaking down norepinephrine and epinephrine into normetanephrine and metanephrine. And this guy here, which works with SAM, upregulated by cortisol, right? This is PNMT. PNMT and SAM take norepinephrine and make more epinephrine, right? So excess cortisol increases how much epinephrine you have. Very important physiology right there. The other thing on the side over here is tyrosine becoming homogentic acid. Homogentic acid has to then become malaloacetoacetic acid, which becomes fumarate eventually and enters TCA cycle. If you can't do that, then you accumulate a lot of homogentic acid in Alkaptonuria. And we're going to see that on the next page as well. But before we get there, let's take a look at these two questions. So the one up here says, a 5-month-old boy is brought to the office by his parents who are concerned that he has developmental delay. He has 3 older siblings, and the parents report that his siblings were much more active and interactive at the boy's age. They just moved to the USA from South America and did not have consistent primary care. Physical exam shows that the boy is unable to roll from the front to the back and does not seem to recognize his parents. Comprehensive lab evaluation reveals impaired BH4 synthesis. What is most likely deficient in this patient? So this would require you to remember this table over here, right, where BH4 is needed for 4 different steps. And the correct answer was serotonin, where 37% of people picked it. 30% of people chose phenylalanine, 14% chose glutamine, and 10% even chose GABA, right? And you can see BH4 is needed to make tyrosine, then to make DOPA. It's also needed here to make serotonin, and here to make nitric oxide. So the correct answer was serotonin. Phenylalanine, right? Phenylalanine is the starting guy. It's already there. You don't need anything to make it. So that was a big mistake. 30% messed up there. 14% chose glutamate, but glutamate, remember, glutamate is another starting thing. You don't need anything to make it. So again, another big boo-boo. 10% chose GABA, but GABA is only related to B6, not BH4. Right, so most of these people were either guessing or trying really hard to remember something, but serotonin was the issue here, right? And it's one down here. Everyone remembers DOPA and tyrosine as the answer because that's related to PKU, either being normal PKU or malignant PKU. But serotonin and nitric oxide are the other guys you have to remember, and they're the guys that have an O in their name, so that's something. But other than that, there really isn't any easy way to memorize this, so just do your best, I guess, to memorize it. And just memorize it, like actual memorize it, keep repeating it or whatever. Serotonin is formed from hydroxylation and decarboxylation of tryptophan, and in PKU, BH4 deficiency can lead to lack of phenylalanine and tryptophan metabolism, leading to low serotonin and other neurotransmitters, which is malignant PKU. This question here says, This URL question is related to the Cori and Cahill cycles again. Okay, so the ammonia stuff. As part of an experiment, healthy volunteers undergo a 12-hour fast and then drink a solution containing radio-labeled alanine. Consecutive blood samples are drawn every 15 minutes for the next 3 hours. Later, you see the tracer is present in blood primarily in the form of glucose. Before alanine can be converted to glucose, its amino group is transferred to what? And that's literally a question coming straight from that image, right? Before you make alanine, the amino group has to be transferred where? So you had an amino group on the glutamate. Glutamate combined with pyruvate. Pyruvate became alanine. The amino went onto alpha-ketoglutarate. That was the answer for that question. Right, so obviously not a very it's a very straightforward question, but it's a question you have to remember that cycle for. Right, so alpha-ketoglutarate was the answer. Alanine and glutamine play an important role in transporting nitrogen in the body. Glutamine is produced by most body tissues and is catabolized primarily by the gut and kidney for maintenance of cellular metabolism and acid-base regulation, respectively. A significant portion of the glutamine used by these tissues is converted to alanine and released into circulation. Alanine is also released by skeletal muscle tissue during protein catabolism as part of the glucose-alanine cycle that helps remove excess nitrogen. And this just goes on to talk more about the same Cahill and Cori cycle stuff. Right? But remember in the Cori and Cahill cycle that one of the important things is the alpha-ketoglutarate, which was related to hyperammonemia because you use up all your alpha-ketoglutarate and you inhibit your TCA cycle in hyperammonemia. The next page talks about the other diseases that came from the chart we just looked at. So you have PKU, MSUD, Alkaptonuria, and Homocystinuria. So let's take a look at them. PKU is either due to phenylalanine hydroxylase deficiency, which means you cannot take phenylalanine and make tyrosine. Okay, so you're going to have low tyrosine there. Or it can be due to low tetrahydrobiopterin, which would be malignant PKU. Tyrosine now becomes essential, so you have to provide tyrosine to this patient. High phenylalanine will lead to high phenylketones in the urine, right? Because you're accumulating a lot of phenylalanine and you ran out of tyrosine. What is phenylketones? Basically, you're going to be making ketones, and those phenylketones are phenylacetate, phenylactate, and phenylpyruvate, which are literally ketones that you're not generally supposed to have. They're not like normal to have in high amounts. And they can also cross the placenta, and their accumulation is believed to cause brain damage. Right, so that's problematic. If a pregnant woman, I thought that was a mosquito. If a pregnant woman has PKU, treatment is to just decrease phenylalanine intake and increase tyrosine in the diet. Also provide BH4 anyway, just in case. What do you see in these patients? You note a fair complexion, eczema, and a musty body odor, as well as brain issues, right? Seizure, growth retardation, intellectual disability. Why do you have fair complexion? Because you're not making tyrosine, right? If you're not making tyrosine, you're not going to make dopa. And if you're not making dopa, that's never going to become melanin. Okay, so everything down the line is kind of not going to be working as well. So it's problematic. Maternal PKU. Again, remember, it's very important to think of maternal PKU because they mention it here. And these phenylketones can cross the placenta, so it's going to affect the baby. But maternal PKU is usually lack of proper dietary therapy during pregnancy. Findings in the infant would be microcephaly, intellectual disability, growth retardation, and congenital heart defects as usual. Right, so they don't really talk about it too much, but just make sure that if you do see a question that seems to be talking about PKU, just give the mother as much BH4 and tyrosine as possible. Screening for PKU occurs 2 to 3 days after birth because at birth it'll be normal thanks to the maternal enzymes from fetal life. It is a disorder of aromatic amino acids, so you will have the musty body odor, but very rarely do they actually mention this in a question because it's kind of like a giveaway. PKU patients must avoid the artificial sweetener aspartame, which contains phenylalanine. And if you're in America and you buy Diet Coke or Diet any soda, if you look at the label, it actually says phenylketonuria contains phenylalanine. It's also something that's written on the label for Trident gum and a bunch of other gums. that use phenylketones for their sweetening. Maple syrup urine disease. This one is one that a lot of students tend to forget. They don't really recall it well or catch it well in the question, but it's related to vitamin B1 and it's related to your branched amino acids, which are isoleucine, leucine, and valine. Right? Why is there a problem with them? That's because your branched chain alpha ketoacid dehydrogenase requires vitamin B1. So if you either don't have vitamin B1 or you don't have enough activity of this enzyme, BCAKD. What happens? You have increased alpha keto acids in the blood, especially those of leucine, and the treatment is just to restrict those guys, right? Restrict branched chain alpha branched amino acids in these patients because they can't break it down, and give them thiamine. So right here I wrote BCAKD is a complex of enzymes found in the inner mitochondrial membrane, and it's a member of this family comprising of pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase, both of which are key parts of glycolysis. BCAKD mutations causes MSUD. Giving high doses of thiamine may help, hence this complex requires the same 5 coenzymes as the other guys. Right? This enzyme actually requires all the same coenzymes as the other two did, which were TPP, a B1 derivative, FAD, NAD+, lipoate, and CoA. Basically vitamin B1, B2, B3, B5, and lipoic acid. All right. What's up with the leucine? So leucine gives 2-keto-icocaproate, and you don't need to know that name, but it's good to see it at least once, just in case it pops up somewhere. Leucine gives that. Isoleucine also gives a similar weird name, and valine gives another keto-isovalerate kind of thing going on. These guys are then supposed to be broken down by BCAKD into acetoacetate, acetyl-CoA, and propionyl-CoA, which are obviously much more, common, right? You've seen those before. It doesn't happen, so you don't do that, and then you accumulate the wrong shit, and you get maple syrup urine disease. Presentation is vomiting, poor feeding, urine smells like burnt syrup, which really, again, is a thing they probably won't mention in the question. But if they do, it's a good thing that they mention it, but, it's very unlikely, and it's more likely that they'll talk about other things, like vitamin B1, or that they're finding low amounts of propionyl-CoA in this patient, right? Something like that. Up here I had a question on PKU, but it's pretty straightforward. It says this is from UWorld also. A 3-year-old boy who recently emigrated to the U.S. is brought to the physician by his parents because he's not yet begun to walk or speak. Assessment of his developmental milestones shows severe intellectual disability. He dies 6 months later from refractory seizures resulting in respiratory failure. Autopsy shows pallor of the substantia nigra, locus coeruleus, and vagal nucleus dorsalis. The underlying condition is most likely due to deficiency of which enzyme? And it's PKU. He has PKU. It is lactophenylaniline hydroxylase. Remember, everything down the line won't work either, so he doesn't make any dopamine. Or norepinephrine, etc. The patient's severe intellectual disability, history of seizures, and abnormal pallor of the catecholaminergic brain nuclei on autopsy suggests PKU. The hypopigmentation of skin and hair and the brain nuclei results from the inhibitory effect of excess phenylalanine on melanin synthesis. You're not going to have any tyrosine, you're not going to have any melanin, and that's it. Alkaptonuria is a question that I don't think I've ever gotten a question on Alkaptonuria wrong, but I've also never really seen many questions on it. It's a really easy topic. It's a congenital deficiency of homogenticid oxidase in the degradative pathway of tyrosine to fumarate, which we saw right here on the side. Right, tyrosine becoming homogentic acid. There's a bunch of steps in between. That has to become malaloacetoacetic acid and then fumarate and go into the TCA cycle. If this step down here doesn't happen, you get too much homogentic acid, and that accumulates. Right? All of this homogentic acid accumulates, so you get pigment-forming homogentic acid building up in the tissue, and you can see it in the skin. It's autosomal recessive, usually benign. Findings are bluish-black connective tissue, ear cartilage, and sclerae. So you can see this dark dot in his eye. That's called ochronosis. Urine turns black on prolonged exposure to air. Right, so that's something that you can get on a question. It's pretty much a giveaway if they mention that. may have debilitating arthralgias, which is probably going to be their presenting condition, right? You're going to get a patient who came in with arthralgias. You're going to have differentials of like rheumatoid arthritis or osteoarthritis, and then they'll maybe mention that his skin has weird pigmentation or his eye has weird pigmentation. And if you're lucky, they'll mention the urine turning black in, standing in air, and that's it. It's called Alkaptonuria. So what is Alkapton? Alkapton is the oxidized form of homogentisate, right? Oxidized. That's why the urine turns black with prolonged exposure to air, because when it's sitting in the air like that, it's getting oxidized. That's generally what's happening there. Patients may exhibit osteoarthritis, valvular heart damage, and development of kidney stones. And that's why this topic is pretty, rare to see a question on, because it's going to be a giveaway, and it's really tricky to like make a question that doesn't come off as a very easy question. Homocystinuria, on the other hand, is a more complicated thing, and you will see questions on it. It does compare with Marfan's, and we're going to see that right now. But let's look at all the different causes, because you can already tell why they like asking questions on it. There's 4 different ways of getting homocystinuria. If you look at this down here, right, you see homocysteine in the middle. You see vitamin B12 and B6. We already talked about the B12 part, where homocysteine becomes methionine thanks to methionine synthase. And that doesn't work in B12 deficiency, so that part we've already talked about. Over here, you have B6 and serine with cystinuria synthase, and homocysteine is becoming cystinuria. Then you make cysteine. And this is all normal stuff. All of this needs to happen. But if you have cystinuria synthase deficiency, you can't do it. Right? So you're going to have excess homocysteine, and more of it is going to get shunted this way, so you're going to have excess methionine. But over here, they tell you that the treatment is to decrease methionine, increase cysteine, give more B6, and give more B12, and give folate in the diet. All of these things, right? Why are we doing all of that? So the reason you're giving more B12 is because since this is happening more, you're taking all your homocysteine, you're making it all into methionine, you're going to use up all your B12. So you have to give them B12. Why are we giving B9? Right? That's the little part that many people tend to skip on. So anytime you give B12 supplementation, it's pretty much a good idea to give B9 as well. But a lot of these steps later on also require B9, so that's another thing that comes up. What else can cause homocystinuria? So you have this step right here, decreased affinity of cystinuria synthase for B6, right? And that's a very silly thing to even have as a bullet point here. So what they're saying is maybe your cystinuria synthase doesn't like the vitamin B6 you have, or it doesn't have high affinity for it. So the only way to fix that affinity issue is to just give a shit ton of B6, right? And then also provide cysteine in the diet, which you should be doing up here as well, you can see, right? Provide cysteine in the diet because you're not making enough of it. The other one here is methionine synthase deficiency. So if you have a deficiency of this here, right? If you have a deficiency of this here, you cannot take your homocysteine into methionine anymore, so you shunt more of it this way. So that's a different issue now, right? That's a whole different thing. It's like a secondary homocystinuria, if anything. So it's not homocystinuria because your cystinuria synthase isn't working, but it's homocystinuria because the other guy isn't working, so all your homocysteine has to be shunted this way. And that's weird, right? And then the last one here, methylene tetrahydrofolate reductase, MTHFR deficiency. This is the one where you just have to give a lot of folate, right? And we don't see this in this image here. I used to have another image where we could see why we provide folate, but I don't have it here anymore. I wrote it here, I think. Let me see. Homocysteine can be metabolized to methionine via remethylation. Methyl tetrahydrofolate reductase deficiency is the most common cause of hyperhomocystinemia. Okay, so that's probably a note from UWorld. But this last part is the one that, with the MTHFR, if you get a question on tetrahydrofolate, right, and something's wrong with folate, and you could tell that the question has something to do with homocystinuria because this entire shit list of symptoms is there in this patient, then you need to remember to just provide folate, right? Now the differences between these two guys, hold on, let me see my mom music. roundabout like that. Excuse me. Okay. So how are you going to know which one of these is the issue in the patient that you get? Well, for one thing, they have to tell you. They have to tell you what's accumulating, what's missing. They might even tell you what treatments they provided and what really helped. Because there's a very big difference between this one, where your methionine synthase is not working, and the other one, the first one, where your cystinuria synthase is not working. And the one in the middle is pretty straightforward. They'll just tell you that providing more B6 made everything okay. So that means that your cystinuria synthase works. It just doesn't have a high affinity for B6. Okay. So what are the symptoms you see in your homocystinuria patient? All forms result in excess homocysteine. We already figured that out. You're gonna have a lot of cysteine, and then you get homocysteine. Okay. What does homocystinuria lead to? You have osteoporosis, a morphinoid habitus, ocular changes, where you can compare this to Marfan's now. So you can see why any question you're going to get is going to have a high comparison with Marfan syndrome, because you have the morphinoid habitus, you also have the ocular changes, which usually gets described in a question with the patient not seeing something correctly unless they tilt their head. But in Marfan's, we said that the lens fans outwards, right? So we're looking at a fan. The lens actually moves upwards. In homocystinuria, the lens looks downwards, okay? So it's going to be downwards and inwards, medially, down and medially. You also have cardiovascular effects, which usually is the cause of death. So thrombosis, atherosclerosis, leading to a stroke or MI. You're going to note the kyphosis, intellectual disability, fair complexion. In homocystinuria, the lens subfluxes down and in, whereas in Marfan's is up and fans out. So a lot of little things here and there, but really not the hardest stuff. I would definitely say it's harder than the other guys on this page, though, because it's not very straightforward. This is so bad. Like, my throat is just extremely dry for no reason. Well, obviously because I'm sick, but the more I talk, it just gets really, really bad. Okay. So cystinuria. Now, this is continuing on from the same stuff. So cystinuria, this is a hereditary defect of renal PCT. Almost all questions regarding the kidney, if it's not about a medication, is usually the PCT that's the issue. And the other place we saw renal PCT being an issue was earlier in nutrition. So what's up here? This is a defect where you don't have any reabsorption of cystine, ornithine, lysine, and arginine. I like pronouncing them like that because it really helps me remember. Cola works perfectly fine too. I mean, obviously this is lysine, but if you just remember all the ines are just not really absorbed, and you remember cola, then you'll know exactly which ones are not reabsorbed. So if they're not being reabsorbed, you're going to urinate all of them, and that's bad because you need them. And this is cystinuria, right? We're not really talking about the other guys. So that means that urination of cystine is the one that's causing the real symptoms here. The excess cystine in the urine can actually lead to recurrent precipitation of hexagonal cystine stones. Right? And those stones are basically going to cause kidney stones. The treatment is urinary alkalization. Just give them potassium citrate or acetazolamide, which is a renal medication. And any chelating agents like penicillamine, where, penicillamine, if you remember, is actually a chelating agent for like so many different things. And this is just one of the other extra stuff you can give penicillamine for. But the main goal is to increase the solubility of cystine stones by just providing a bunch of water. Okay, that's the other thing. And I've actually seen that being mentioned in questions where the person had not been drinking enough water. They'll tell you that. The other thing you can see in the question as a giveaway is the urinary cyanide nitroprusside test. Right? If you forgot about the cyanide nitroprusside test, and then they give you a question about some patient presenting with a kidney stone, and they just tell you they're doing the cyanide nitroprusside test, then boom, right? That's a question on cystinuria. Cystine is made of two cysteines connected by a disulfide bond. Just a little note for people to know, really. And what is the defect prevents proper reabsorption of basic or positively charged amino acids. Dietary restriction of salt and protein, especially methionine, is necessary. That was probably from another question I did. Cystine, staghorn, calculi, kidney stones. Formation of cystine stones can occur in the ureter or bladder also. Patient will present with nausea, vomiting, a colicky pain, and hematuria. Right? They don't really tell you the symptoms that the patient is going to present with. I don't know why, so that's why I put that here. May note hydronephrosis and pyelonephritis eventually as well because of the kidney stones. Cystine stones are often not visible on most x-rays, CT scans, or ultrasounds. Urine odor has a smell of rotten eggs due to increased cystine. Right, so very important to note that you're not really going to see the stones on x-rays, CT, or ultrasound, whereas most other stones you can. And this actually gets mentioned again later on where you talk about all the different stones. I think it was in hematology somewhere. Alright, so make sure you keep that in mind. So cystine, also remember cystine as cysteine to remember the hexagonal shape. Propionic acidemia. This wasn't really there in previous first aids. Propionic acidemia, so this is pretty new. Let me see. Okay. 13 notifications. Cool. Propionic acidemia is an autosomal recessive deficiency of propionyl-CoA carboxylase, which then leads to excess propionyl-CoA and low methylmalonic acid. Right? And propionyl-CoA we've already talked about. Propionic acidemia we did some questions about already. This was a topic that UWorld was really talking about a lot, and now it's in first aid as well. Findings are poor feeding, vomiting, hypotonia, and anion gap metabolic acidosis, and hepatomegaly, as well as seizures. All usually due to stuff related to hyperammonemia in one way or another. Substances that metabolize into propionyl-CoA cause you to vomit. And they are valine, odd-chain fatty acids, methionine, isoleucine, and threonine. Right? All these odd-chain fatty acids. Now, why the odd-chain fatty acids? So let's go back and look at that, right? Because that was actually a pretty important thing. It was right here. Right here where we talked about gluconeogenesis, we have the odd-chain fatty acids give you one propionyl-CoA, which can enter TCA, right? And propionyl-CoA is derived from metabolism of valine, isoleucine, methionine, threonine, and odd-chain fatty acids. So when you don't have the ability to work with that, you get propionic acidemia, you get too much propionyl-CoA and low methylmalonic acid, and it's not going to work out well for that patient. Right, so let's come back to that topic. We already did the practice questions on it, but when you see a child, right, and they tell you this, they're going to give it to you. They have to, because all these symptoms are pretty non-specific. None of these symptoms are very much like, oh, it must be propionic acidemia. So when you see these symptoms, you want to assume the high propionyl-CoA is giving you propionic acidemia. And the question is usually going to be about what you should avoid in the patient. So you just pick one of these as your answer choice, and that's it. All right. After this, they start talking about glycogen regulation by insulin and glucagon, as well as epinephrine. A lot of really good notes here. You get your glycogen, and then glycogen storage diseases, and then a lot of questions on the fat stuff. That's going to be the last thing. I'm going to do that tomorrow at noon, because I really can't talk anymore. I'm just choking up with my dry throat and sick self. My nose is clogged up too, which is really annoying as fuck. But yeah, thanks a lot for joining for now, and then tomorrow we'll continue on from here and finish it up.